We welcome everyone today to our second webinar in our COVID webinar series. Today, we will be discussing mental health considerations for patients and healthcare workers. Next slide, please. I am Courtney Nisbet, Associate Director of Quality at CPQCC. Thank you for attending today's webinar. Why have a webinar on mental health? Because it's a priority and there is no better time than now. Our past two webinars in our COVID series have primarily focused on research and practice guidance. We've discussed some very important registries nationally and internationally, and potentially more to come. For now, we are taking a different approach today with our webinar focus and talking about a very important topic, mental health. There is a growing crisis of the psychological impact on many during COVID-19. Our speakers today will be sharing experiences and valuable information to support patients, families, and healthcare workers. We have talked about how to protect patients, families, and healthcare workers physically, and now is the time to talk about protecting them mentally. Next slide, please. If you or others are experiencing a crisis, please reach out. We have listed a few resources here, and we ask that you please share with others. Next slide, please. With regards to logistics, all attendees are automatically muted upon entry. The chat function has been disabled, and if you're having technical difficulties, please utilize the Q&A box. We also asked for folks to utilize the Q&A box to submit any questions you have for the presenters. We will be answering a select number of these questions relevant to the topics presented today during the Q&A portion of the webinar. The remainder of the questions will be used to assist us in developing our future webinars in this series. To note, the slides and webinar recording will be made available on our joint COVID website shortly after the webinar. Due to the rapidly changing guidelines around COVID-19, the slides and recording will be taken down after a few weeks. I also want to highlight our joint CMQCC and CPQCC COVID website. We have had over 28,000 hits from folks nationally and internationally over the past month. There have been over 1,300 views of the previous webinar recording, and over 750 watched that live. This website is a great COVID resource, and I encourage all of you to visit the website. Next slide, please. I want to note that the information shared in this webinar series and on our resource site are examples of how hospitals, healthcare workers, and families in California are responding to COVID-19. We understand that each hospital is working from a different set of resources and constraints, and that some recommendations presented may not be applicable to your hospital setting. Any guidelines and recommendations should be adapted to fit your local needs. Also, as this is a rapidly evolving public health situation, we encourage you to take into consideration the most recently available local health department and CDC guidance when developing your internal protocols. Next slide, please. And now I'd like to highlight and welcome our presenters today. We are honored to have these folks present their experiences with COVID-19 as it relates to mental health and well-being for patients, families, and healthcare workers. In addition to the physicians from UCSF and Lucile Packard Children's Hospital, we are so lucky to have a NICU parent representative speak today. Thank you to each and every presenter for their support of this webinar. And as a reminder, we will close out the webinar as time allows with a Q&A session. Finally, I would like to recognize our physician leaders at our California Quality Collaborative. Dr. Elliot Main, the Medical Director of CMQCC, Dr. Henry Lee, Chief Medical Officer, CPQCC, Dr. Jochen, Chief Quality Officer at CPQCC, And last but not least, Dr. Jeffrey Gould, Chief Executive Officer at CPQCC and Co-Principal Investigator of CMQCC. Next slide, please. It is my pleasure to introduce Dr. Amanda Yeaton-Massey from UCSF. Amanda?
Courtney, thank you so much for the warm introduction and for having me here today on this very important webinar. Next slide. So I like to think about my whole practice really in terms of this quote: without mental health, there can be no true physical health. And I think for all of us right now in the time of COVID-19, this has become very apparent that we really can't provide care for our patients without thinking about their emotional well-being in addition to their physical well-being. Next slide. So I'd like to just remind all of us that being anxious and worried right now is so normal. Patients and providers are all in a state of heightened activation due to the uncertainty that we are faced with in the world. Next slide. So a reminder to patients, providers, and to myself that in order to take care of others, we must put on our oxygen masks first. What do I mean by that? So when we care for our patients, we have to consider our own physical and emotional well-being in order to do a good job. So this talk is going to be really a practical set of tools for you to help provide your patients, and I hope you can utilize them for yourselves as well. Next slide. A bit of epidemiology. So pregnancy is associated with a heightened state of anxiety even without a pandemic. So estimates range from about 1 to 5 to 1 in 7 women will be affected by anxiety and depression in pregnancy or postpartum. And this makes anxiety and depression the #1 complication of pregnancy and childbirth, the #1 complication. Next slide. So there's a wonderful informal survey that was done at the University of Michigan by a perinatal psychiatrist by the name of Dr. Maria Music. And she surveyed obstetricians, pediatricians, and psychiatrists at her university. And 3 areas of concern emerged for perinatal women. So these break out into pregnancy, labor and delivery, and postpartum. Pregnant women expressed concern about getting the virus at an appointment or during their hospital stay. They expressed concern about not seeing a provider in person and things getting missed, specifically concerns about anomalies. They talked about work issues and being unable to work from home because they were essential workers, or their partners being unable to work from home because they were essential, and then concerns about their partner bringing home an infection. In terms of labor and delivery, I think many of us have seen the images that came out of New York City, the headlines from the New York Post about women not being allowed to have a support person in labor. That is no longer true, but I think it provoked a great deal of anxiety for both pregnant women and their partners. And many patients expressed concern and continue to express concern about separation from their partner during labor. People also expressed concern about separation from their baby if they were COVID positive, and grief about the loss of their imagined labor and delivery experience. Postpartum, lack of in-person support was a major concern, so not being able to leverage support from grandparents, in-laws, doulas, friends. Worries about bringing baby in to peds visits for well baby checks and getting an infection. Grief about being robbed of early motherhood and that experience that they had imagined, and relationship issues. It's very difficult to be sheltering in place in a stressful time with a partner. Next slide. So all of these anxieties that are becoming apparent in the time of COVID-19 highlight the fact that screening for anxiety and depression right now is more critical than it ever has been. And you really can't tell by looking at a patient what they are feeling. We have to ask, we have to screen. Next slide. It can be overwhelming to try and come up with a screening program, and many hospitals already have screening in place, particularly on the outpatient side, and many don't have a screening program in place. And we can use this, I think, as an opportunity to highlight the importance of screening. And I want to make sure that everyone on this call is aware of this wonderful free patient safety bundle on maternal mental health and screening for depression and anxiety. This was put out by the Council on Patient Safety and is endorsed by ACOG, SMFM, and the Council of Nurse Midwives, among a number of other organizations. And it really provides a step-by-step guide on how to screen, what to screen with, and what to do in the case of a positive screen, because that often comes up as a reason for not screening. If I find a patient who's suffering, if I have a patient who needs resources, where do I send her? Next slide. So let's talk a little bit about COVID-19 and why people are feeling so stressed and so anxious right now. So here are 4 things that really trigger the body's stress response. And those are novelty, uncertainty, lack of control, and lack of social support. And coronavirus really ticks off all of these boxes. It's novel. Things are very uncertain right now. We have limited control over what's happening in our world. And our social supports have been turned into these virtual experiences that are unfamiliar to us. Next slide. So we're going to talk about each of these 4 triggers of the body's stress response and what we can do to help make some of those stressors a little less stressful. So they call it novel coronavirus for a reason. We've never seen a virus like this before. Our bodies haven't, our political landscape hasn't, and our economy hasn't. So what can we do to make it less novel? We can provide information and education for our patients and for ourselves. And we can get that information and provide that education from trusted sources. So the Society for Maternal Fetal Medicine, the American College of OBGYN, and a really wonderful project out of the University of North Carolina called the 4th Trimester Project, all have excellent patient-facing resources about coronavirus and pregnancy. Next slide. Uncertainty. So all of this is so uncertain, and initially with the shelter-in-place order, things felt like they were changing on a minute-to-minute, hour-to-hour, day-to-day basis. Things are changing a little bit less rapidly, but there is still a large degree of uncertainty. So those of us who are parents are trying to figure out, where will my kids go this summer? Will they have camp? When will school start? Will I have a job? And all of those things can make us ruminate or kind of chew on our thoughts over and over again. And that can lead to an increase in the body's stress hormone, or cortisol, and that subsequently triggers a lot of stress and anxiety. So we can't take away the uncertainty, but we can help our minds deal with that uncertainty. And the way that we can do that is really turning on the prefrontal cortex in the brain to settle down the mind in response to that uncertainty. There is a wonderful app that came out about 2 weeks ago called COVID Coach. The U.S. Department of Veterans Affairs made it, but it is intended for anyone and everyone. It's free on iOS and Android. You do not have to register. They track no information, and it has tools for patients and providers, really anyone who wants to use it, to track their mood, to track how they're feeling. And in the screenings, they then provide you with tools that you can use to help. So mindfulness meditation exercises, yoga, breathing exercises, body scans, you name it, it's in this app and it's free. It's a really wonderful resource for patients. It also, as a sidebar, has this piece that connects patients to local resources and helps with things like how to apply for unemployment. So it has a little case management feature in addition. Next slide. So what about this lack of control? So I love this picture from Inside Out. You have Joy here in the wagon, and she's really enjoying this lack of control, but most of the other folks in the wagon with her aren't enjoying that lack of control very much. And when things are out of control, like they are right now, we can focus on what we can control. And it's much easier to control our behaviors than our thoughts. And to be very clear, it is not always easy to control our behaviors, but easier than our thoughts. So what can we do? We can eat well, we can sleep well, we can move our bodies. We can help our patients by making sure that they have the resources to eat well and a safe place to sleep, and encourage them to move their bodies as well. And we can help people make plans. I think often the birth plan comes up, but the postpartum plan is not frequently made. And I would encourage you all to talk to your patients about the plans that they have for postpartum. Logistically, what they plan to do for food, how will they get groceries, what is their plan for sleeping overnight, how will they divide responsibilities with their partner. And encouraging our patients to ask for help, and encouraging ourselves to ask for help and to be open to receiving help when it is offered to us. Next slide. So lack of social support is a huge one right now, and all of us are being told to shelter in place. We are at home, we are not seeing people like we usually do, and there's this hashtag, alone together, we're all in this together, and we are all trying to navigate this space in which we need and crave that social connection as human beings, but we are not able to have it in person in the same way that we did before. So very important for ourselves and for our patients to try and figure out how can we connect with family and friends. So practicing physical distance, but emotional connection. So FaceTime, Google Hangouts, chat, Zoom, whatever works for you, however you want to connect. Support groups can be really wonderful for our perinatal patients. And on the next slide, I will share with you some resources. Being of service can be very helpful in terms of mitigating the anxiety that comes from a lack of social support. So for those of us in the helping profession, I think most of us entered this profession in order to be of service to others. So, calling on that now and finding ways to serve your patients and your community. Practicing self-compassion is huge, being forgiving. You eat that extra piece of cake, instead of beating yourself up, say, wow, it was a hard day, I ate a piece of cake, move on. Practicing gratitude, a really helpful thing can be sitting down at night with your family and just thinking about a couple of things that you feel grateful for. And finding humor and laughter still, in spite of all of the very difficult things that are happening, finding those kernels of joy. Next slide. So if you take nothing else from my talk today, I hope that everyone leaves knowing about Postpartum Support International. Postpartum Support International is an incredible organization that has been around since the 1980s. As their name would imply, they are an international organization. They have a very robust presence in the United States and services all over. And they care for women in pregnancy and postpartum. So while their name is Postpartum Support International, they really are a perinatal focused organization. They have a wonderful warm line that patients can call or text to get help. They provide services in English and in Spanish. And you can see this little purple rectangle in the lower left corner that you can click on to find local resources. And there are local area coordinators that can connect patients with one-on-one services. And there are a multitude of weekly support groups that are offered for free to patients. So their address in the lower right corner is postpartumnet.net. And again, Postpartum Support International. Next slide. So take-home points today, anxiety and worry are really universal right now. There is help out there for all of us, for providers and for patients. In order to care for our patients, we need to put on our oxygen masks first and take care of ourselves. And in our toolkit, we have all of these ways to help with the triggers for stress. So we can combat novelty with education, uncertainty with settling our minds, lack of control with controlling the behaviors that we do engage in, and connection to mitigate that lack of social support. Next slide. I'd like to acknowledge a lot of the slides that I used for the control of stressors came from a wonderful presentation by Dr. Maria Music from the Michigan Child Care Collaborative. Next slide. And I'd like to turn over the presentation to Dr. Susan Hintz now. Thank you so much.
Thank you so much, Dr. Yeaton-Massey. That was great. I'm Susan Hintz, and I will be briefly presenting the results of the survey that was administered after the second webinar on April 10th. And that included a number of questions that related to unit and parent and family impact of the COVID crisis. So why include queries like that on that survey? Well, certainly the data that we have available to us thus far suggests that vertical transmission of the SARS-CoV-2 virus appears to be limited or unlikely, and therefore COVID-19 in terms of the disease itself may not be expected to be the substantial impact for the newborn NICU population. However, certainly the effects of the COVID-19 crisis, and particularly hospital policy changes around family visitation, their own access to resources, and many other stressors for parents have been felt profoundly by our NICU families, as well as by all our staff and providers in the unit. So very clearly, these survey questions were not meant to be comprehensive, but rather just to highlight some of the main touch points that we know you all are concerned about. Next slide. So this first slide just gives you an overview of the survey participants, and you can see that of the 787 who attended the second webinar, about 27% completed the survey, and that's actually pretty good for a survey. And you can also see that from the breakdown of California inside versus outside, that these webinars really are reaching beyond the state. You can also see here just an overview of what captured the primary position or role for those who responded to the survey. Next slide, please. So this slide shows just a breakdown of the units where the survey participants worked. And if you go down the list a little bit, you can see that about 30% of the respondents worked primarily in the NICU or newborn nursery. Next slide, please. In answer to the question that we posed, has your NICU changed its visitor policy due to the COVID-19 pandemic? Not surprisingly, almost all of the respondents indicated that their policy had indeed changed. And you can see the breakdown from California versus not inside California. Next slide. And in drilling down on more of the details around those COVID related visitor policies, the vast majority indicated that only one family member could be at the bedside at a time. And about half of the California respondents that you see there, 45%, indicated that the visitor had to be the same person, identified and consistent throughout the hospitalization. And as we all know, sometimes those hospitalizations are very long. Next slide. So in response to the question, does your NICU have or use technology to facilitate family or parent communication during this period? 1/3 to 1/2 of the respondents indicated that they either didn't have that technology or that they didn't have enough. If you look further down, a group of individuals responded as others, and in the comments, some indicated that parents were allowed to use their own technology, but as we know, some of our parents don't have access to that kind of technology. Some also indicated that they had Angel Eye or NICView, but again, as we know, that really doesn't usually facilitate the kind of visits that we would like. Next slide. We also asked if families had been impacted by reduced availability of transportation or local housing due to the crisis. And about 1/4 of California respondents indicated that they had. But if you note further down, about 1 in 5 indicated other. Many of those comments revealed that it wasn't really known, or the respondents weren't really aware of whether there was an impact there. And then, of course, there were some other comments specific to housing issues. Next slide, please. And finally, really importantly to the topics that we are going to continue to explore in the presentations to follow, about half of the respondents said that their units did not have any initiatives or any special projects to alleviate stress or anxiety or to try to address the limited resources that parents and families have during the COVID crisis. Now, some of the respondents did indicate that they did have some new activities. And to that end, next slide, you can see here a list of some of those activities that were highlighted. And these include increasing meal support, implementing telehealth solutions for lactation, child life, psychology support, and for bedside family visits. And with that, I think next slide, it's a perfect opportunity to introduce Jennifer Canvasser, who is a great advocate and partner.
Well, thank you. I'm really pleased to be here. So, hey everyone, I'm Jennifer. I'm the founder and director of the Necrotizing Enterocolitis Society, and I'm also a social worker. And before we dive into what parents want providers to know during this pandemic, we could go to the next slide. I just want to make two quick comments on the survey results. So the first, around the 45% of respondents who reported that just one family member is allowed at the bedside at a time, and how that person must be consistent throughout the hospitalization, which could be very long. So I'm going to dive into this more in detail over the next 10 minutes or so, but I just want to encourage units with this type of policy to really consider modifications, ways to keep parents and babies together, because being in the NICU is already incredibly traumatic, and we really don't want to make it unbearably worse for these families. And I encourage you, it might be helpful to connect with other units who are allowing both the mother and the partner to be with their baby at the same time, perhaps gaining insight from your family advisory councils on how to figure out some solutions and ways to implement this in a safe or practical way. Go to the next slide. I also wanted to comment on about the 51% of respondents who are not yet offering additional resources for families during the pandemic. So we've had to implement some pretty drastic policy changes in our perinatal units, obviously. And so I know we want to offer additional resources and support, but perhaps it's unclear what those should look like. And so I'm hoping that today's webinar will provide some guidance and some ideas. But I also want to say that it's always helpful to actually talk to the families that are in your care, ask them what they need. Talk to your family advisory councils, connect with other units, and I would just encourage everyone to do something and just keep trying until you find something that works for your unit and your families. We'll go to the next slide. So this may seem obvious, but we really need to do everything we can to keep parents and babies together. They need each other, and staying together is really within the best interest for both their mental and physical health. I understand the incredible challenges and the risks, but I believe that there are ways that we can overcome the barriers and mitigate the risks. You know, the next slide, because mothers aren't visitors and neither are dads. Mothers and neonates really should be considered as one. They're one unit, and parents are just as essential as nurses and doctors. And so our policies really need to reflect this truth. Go to the next slide. It's obvious that mothers need their partner during delivery, and for babies or children who are hospitalized, mothers and partners are just absolutely essential. We can't expect our NICU moms to be alone in the unit without their partner. We can screen both parents with the same protective policies that we use for all of our other essential healthcare workers who come in and out of our units every day. You can go to the next slide. And I'd also like to go ahead and highlight some perhaps obvious reasons why it's really critical to keep parents and babies together. So when we're limiting access, parents' access to their baby, we are actually disrupting their access to the baby's access to mother's milk, and clearly that's problematic. You can go to the next slide. Limiting parents' access also disrupts skin-to-skin care. You can go to the next slide. It also interrupts these nurturing interactions that we know are critical for the infant's cognitive development, and they're so essential to the parent's mental health. You can go to the next slide. And we are also then disrupting a parent's ability to advocate for their baby. We know that parents know their babies better than anyone else. They're the most essential member of their baby's care team, and so we really need the parents there to be able to become that advocate for their child. You can go to the next slide. And for NICU parents, it's really critical that they learn how to care for their medically fragile baby while they're still in the NICU, both parents. Both parents need time to adjust and understand their NICU baby's needs before they're discharged home. Go to the next slide. And so basically, when we limit parents' access to their baby, we're disrupting an infant's ability to thrive and the parent's mental as well as physical health. Go to the next slide. And I know that there's been a lot of great technology that's taking place. And I think, that's a wonderful alternative when the parents cannot be physically present. But of course, it will never be able to replace the magic of physical nurturing interactions between the parents and their newborns. And so we really need to do everything that we can to help ensure that both parents can physically be at their baby's side. Go to the next slide. And so now I'm going to transition over to some questions that I would just like everyone to consider. So the first is, how are your policies comparing to others in your region? I think it's probably obvious, to just want to say out loud, that parents from across the U.S. are connecting with each other on social media and online platforms, and they're sharing their stories and the hospital policies that they've experienced themselves. And this wide range of policies and not knowing how, if, or when a policy is going to affect their family is really causing profound anxiety for parents. And this drastically different information that's out there can even, or maybe even is, jeopardizing the parents' trust in their care teams. So I think it's really important for you to consider how your policies compare to others. And go ahead and go to the next slide. We'll go to the next question I wanted to pose are, how consistent are your policies? We know that the COVID-19 situation is rapidly evolving and changing. And so how is this rapid change affecting your patient families? I know just from talking with the families that the Next Society is in touch with the NICU families, the inconsistencies and the frequent changes, both between and also within units, it's causing confusion, anxiety, frustration. And this is especially true for the NICU parents who have been in the unit already for weeks or months, and so they've experienced multiple policy changes already. So you can imagine what that's like when they were first admitted, both parents were allowed, and now it's just one parent allowed, and how the effects of that. Go to the next slide. Also, are your policies informed by evidence? Again, I understand that COVID-19 poses intense risks, and so absolutely we should be limiting the number of individuals in our unit so that only essential bodies are coming in. But we have to recognize that both parents are those essential bodies, right? And we can implement the most protective policies that are informed by evidence so that both parents can physically be with their baby. And go to the next slide. It's especially important right now to practice patient and family-centered care. We know there's intense fear, anxiety, uncertainty, but we can remain family-centered by engaging our patient advisory councils and committees, getting their feedback on how to implement the most protective policies in a way that really protects the physical and mental health of both our providers and our patients. We can go to the next slide, and just a friendly reminder of the core concepts of patient and family-centered care. They include dignity and respect, information sharing, participation, and collaboration. And basically, this means just keeping parents informed, engaged, empowered, and realizing that they are the most important member of their baby's care team. So really these concepts are even more critical right now during the pandemic. Go to the next slide. I also want us to consider how we're recognizing the needs of the entire family beyond just the mother and baby. We know that the health of our mothers and our babies are intertwined, but so too is the health of the family unit. And so perhaps we can look to our perinatal social work team who can help us take a more holistic approach to caring for the family and considering their needs. Go to the next slide. Another question I'd like us to consider is how is your NICU team helping families prepare for discharge during a pandemic? I mean, who do they reach out to with concerns? What are their next steps, and what does their follow-up look like? What special precautions should they be taking? And just looking at how have you adapted your discharge plans to reflect the pandemic that the families are going to experience and the reality that they're going to experience once they go home with their baby. And go to the next slide. I also want to highlight how this pandemic is affecting our NICU graduates. And so I'm going to use this family as an example. This little boy, Seth, that you see here was born prematurely, and he survived surgical neck. And he was recently admitted to the PICU, not for COVID-19, but his mother was only allowed to visit him for 2 hours a day. So Seth would of course, cry, scream, and he would resist the care team because he needed his mother's physical presence for more than 2 hours a day. And so while his mother was reliving the trauma of the NICU, coupled with the trauma of being in the PICU during COVID-19, she was being forced to walk away and leave Seth as he screamed and cried for her to stay. And so I share this story because our policies are affecting families in really heartbreaking ways, and they may sound like they would work on paper, but then when we see them play out in real life, you can tell that they're not working for families or for our babies and children. You can go to the next slide. I also want to emphasize that clear, consistent, open, honest, empathetic communication with parents. Obviously, it's always critical, but it's so especially true right now during the pandemic when we're all anxious and afraid. You can go to the next slide. So the health of our families is in your hands. I know it's a tremendous responsibility that mothers and babies are relying on you during the pandemic, but the ways in which both parents and babies are experiencing your care, it will stay with them for a lifetime. And so building trust and rapport with patient families is essential, especially during the pandemic. Shared decision-making about what's best for the baby is essential. And just a friendly reminder that there was no one that's more invested in the health of our babies than parents. Parents are your most committed advocates, so please engage them and allow them to help you find strategies that work. You can go to the next slide. And so before I hand it over to Dr. Shaw, I just want to share a few resources. The first is from the March of Dimes. They have an educational webinar series. These are all free. I think most NICU families would really appreciate these. You can go to the next slide. The next is an app called My NICU Baby from the March of Dimes, another great resource with relevant information about the COVID-19 crisis. Go to the next slide. And then the next one is a resource that I developed for the Next Society a few years ago that I find to be especially true right now during this time of great uncertainty. Go to the next slide. So I just want to first thank the NICU parents who shared their COVID-19 insight and stories with me. And huge thanks to all of our healthcare providers. I know this is an incredibly difficult time, so thank you for your tremendous commitment to the health of our moms and babies. And thank you so much. I'm going to hand it off.
Hi, my name is Richard Shaw. Thank you, Jennifer. I'm a child psychiatrist, and I am the psychiatric consultant to the Children's Hospital at Stanford and also to the NICU. And I think it's been interesting for me in my clinical work to see that even though the actual number of consults in the general pediatric hospital has decreased during the COVID time, the number of consultations we've had to the NICU has actually increased. Next slide, please. I'm going to talk a little bit about COVID, but before I do that, I think it's essential to really understand the whole context of what it is like to have a baby in the neonatal intensive care unit in terms of the impact it has on parents. When we are trying to understand how parents adjust to the stress of having a premature infant, we can use two different models. One is the grief and loss model, where we talk about the loss of the perfect or imagined baby and the various grief reactions that occur. But in this talk, I'm going to focus more on the trauma model, where we can look at the birth of a premature infant as a traumatic and stressful event. And in fact, often it's not one single trauma. It is often unexpected, the birth, but usually parents often will have serial bad news about medical or other prognosis things that can affect them. And we often talk about the term of continuous post-traumatic stress disorder when we're talking about the reactions that parents have in terms of their experiences in the NICU. Next slide, please. So the concept of medical post-traumatic stress disorder now is fairly well recognized, and it describes the trauma reactions that parents and patients have in response to a diagnosis of a serious or chronic illness. Medical PTSD is a little bit different from the type of PTSD people experience when they have a traumatic event like a rape or an assault, or perhaps going through a traumatic motor vehicle accident. With typical PTSD, individuals are able to try to avoid that stress by not going back to the scene of where they were traumatized. But in the context of having a medically fragile child or baby in the NICU, it's actually impossible to practice that avoidance that is common in PTSD, because the actual source of the stress is the parent's infant, and that stress happens when they're with the infant and when they're not. There are other issues that make medical PTSD a little bit different. You can see here on this slide the 4 major categories of PTSD symptoms that psychiatrists use. The re-experiencing, flashbacks and nightmares. Often in the case of the NICU situation, parents are having ruminative, future-oriented fears about their infant's treatment, prognosis, or potentially even their death. I mentioned already that it's hard to avoid them because the traumatic event is located internally in their child or inside of them. The negative cognitions often have to do with irrational feelings of guilt that most NICU mothers in particular have, feeling that they may have done something wrong, even though it's usually based on irrational thoughts. And then that increased arousal, which often takes the form of a hypervigilance to the infant, scanning their bodies, looking at the monitors, imagining things are going wrong medically. And we often see that this pattern can play out later in the form of a pattern of over-anxiety about their child's physical health. Next slide, please. So if we look at the prevalence of PTSD in NICU parents, it may actually be higher than postpartum depression. Average rates of PTSD in NICU parents are around 20 to 30%, but many parents will have isolated symptoms of PTSD that can actually be quite severe and debilitating. And in this study, you can see that up to, all mothers had 1 symptom of PTSD, and at least 50% had 3 symptoms of PTSD. These symptoms of PTSD are often unrelated to the infant's medical status and have much more to do with the parents' coping and individual makeup of what they bring to the situation. Next slide, please. You can see from this slide that PTSD symptoms do not necessarily go down over time. In this study, they looked at PTSD symptoms in parents of premature infants, and they had no reduction in symptoms at 14 months follow-up. This is really important thing and a point to note because I think some people have this idea that it's just normal to have a stressful response and that this is something that people get over. But if diagnosis of PTSD is made, we can anticipate long-term symptoms and that there can be a severe impact on parents because there are often complications of depression, alcohol and substance abuse, and other negative adverse events. Next slide, please. This slide was based on a study we did several years ago. We looked at PTSD symptoms in mothers and fathers immediately after birth, around 2 to 4 weeks while they were still in the NICU, and then at 4 months after birth when the babies had usually been discharged home. And you can see that the mother's symptoms of PTSD did go down, although they still remain symptomatic. But what was interesting in this study is that symptoms of PTSD in fathers actually increased and were higher than the mothers at 4 months. So this has really important implications for screening that I'm going to talk about in a moment, about the timing of when we screen parents for PTSD and other mental health issues. Next slide, please. PTSD not only affects the parents, but it can also affect their infant's outcomes. This is a Swiss study that showed that parents with PTSD had infants around 18 months of age who had a much higher frequency of sleeping and eating problems. Next slide, please. And the other important concept to mention here is that of the vulnerable child syndrome. This syndrome that is probably well known to most of you describes a constellation of symptoms that are very common in children who have serious medical illnesses or histories of prematurity. And it seems that parents who have PTSD are particularly prone to be overprotective, to be overly anxious, to overutilize healthcare, and also to have difficulties with limit setting that can result in behavior problems in their children as they get older. And what's interesting is that many parents associate disciplining with flashbacks of having their infant in the NICU. Next slide, please. So just a word now about specific issues related to COVID. So since this is so new, we have no studies really to look at the impacts of COVID on the mental health of parents, but we can look at a large study here from China, over 1,200 respondents from 900 cities. And you can see, not surprisingly, that there are elevated rates of depression at 16%, anxiety at 28%, and stress or post-traumatic stress at 8%. Next slide, please. The other issue that has been highlighted already by Dr. Hintz is the changes in visitation policies. And here I just want to outline some of the particular anxieties that we know also from Dr. Yeaton-Massey's talk that are common in parents in the NICU. First of all, there is the fear about infection to themselves. Obviously, also there's been some cases widely reported of neonates being infected with COVID, and even though they haven't done poorly medically, this is another anxiety for parents. And then with the visitation policies, with one parent being in the hospital and the other one at home, potentially working or looking after other family members, there's anxiety about the partner becoming ill. The next issue is just the loss of the co-parent support at a time where mothers, who usually will be the ones who are at the bedside, are potentially having a very difficult time with symptoms of anxiety and post-traumatic stress. Not having the co-parent present is a significant factor in making it difficult for them to cope with this. There's also the isolation that's already been mentioned, not being able to have visitors and extended family. And then also the issue of parental bonding and attachment. So having a parent being absent during this critical period when bonding should be taking place can also we can anticipate may have issues and complications downstream. Next slide, please. So what can we do? I'm going to talk a little about screening and then some of the interventions that we're using in our NICU at Stanford. Next slide, please. It's really important to screen. We do universal screening of mothers and fathers in our NICU, and this, I think, should be something that should be implemented in all NICUs. We screen for depression, anxiety, and PTSD. We're screening just once at the moment, but as you can tell from my earlier slide, there's probably a really strong case to be made for screening to take place more than once during the NICU hospitalization and in the high-risk infant follow-up clinics. Next slide, please. There are interventions that we can use to reduce symptoms of post-traumatic stress. We have piloted a 6-session intervention that's called PROMOMS for Preemies. This is an intervention that's offered to mothers, 2 sessions over every week for over a period of 3 weeks. Next slide, please. This intervention relies on what we call trauma-focused cognitive behavior therapy. This is an evidence-based treatment initially developed in the VA with veterans to treat PTSD, and we have adapted it for the NICU population. It includes psychoeducation about PTSD, cognitive restructuring, teaching relaxation techniques, and one of the most powerful techniques or components is writing about the traumatic birth and NICU experience and processing that with the therapist. We also incorporate what we call infant redefinition, which is a form of helping the parents sort of reimagine or reconceptualize their infants and themselves as being competent and able to negotiate the stressful experience. This therapy we've offered individually and in a group format, and currently we're also using it by doing it by telehealth to allow access to parents who are not able to come into the hospital. Next slide, please. Just quickly to show some of the data from the study to show how effective this very short and cost-effective technique is. You can see the first box, symptoms of trauma. The red slide are the people who had the intervention. The dotted blue are the controls. So you can see decreases at 6 months for depression, PTSD, and anxiety. Next slide, please. The other thing we're offering at the moment are groups for fathers who are often not in the hospital. These are done remotely using telehealth, and a lot of the focus from some of our groups has been on what it's like not to be able to be present in the NICU, concerns about childcare, financial issues. All of these things have been greatly amplified by COVID. For programs that don't have robust psychological consultation services in their NICU, there are other things that still can be offered. I put up here a list of mindfulness interventions. Insight Timer is a great app. Headspace now being offered for free for healthcare professionals, and Calm. These can all be downloaded, and the applications are really helpful. We have a hypnosis app. The website is up there. This hypnosis app can be used to help parents deal with issues like insomnia, stress, anxiety, pain. And then another simple technique is just asking parents to start journaling about their experiences. This can be therapeutic in and of itself, even if there's no psychotherapy going on. Next slide, please. So now I'm going to hand over to Dr. Prophet.
Thank you, Dr. Shaw. So, real pleasure to have the chance to speak to you all today. I wanted to quickly just call out Dr. Brian Sexton, who is an associate professor at Duke, with whom I've been doing a lot of my work. Next slide, please. So obviously, as many of the speakers have pointed out, and I will be speaking mostly about healthcare workers in my allotted time, these have been tremendously stressful times for many, physically, but also mentally. And while in the NICU and maybe in the OB space, we have been relatively spared the extreme stress that many of our colleagues are experiencing in the adult world, there nevertheless have been substantial restructuring and changes to our daily lives and fears that have crept into the daily work. Next slide, please. So this is a short questionnaire we developed to measure work-life balance a couple of years ago. And if you kind of go through the questions here, you can kind of see like how many of these questions you might really identify with, except some of them. And nowadays you're actually all the time home and not late from work. But I've certainly been drinking way too much coffee here at home. I think I'm on my 5th cup already this morning, and I used to just drink 2. Many of us maybe don't sleep as well anymore, and if you routinely sleep less than 5 hours a night, you actually have a substantial 40% increased chance of all-cause mortality. The reason, next slide please, I'm showing you this scale is that as we are all impacted by all the changes and the anxieties around COVID-19 and the changes in our health care, in our role as healthcare providers, but now also in our role as teachers and changing role as partners at home, we have to recognize that all of these anxieties will impact the care that we provide to our patients. And so in this slide, we actually looked at almost 400 work settings and looked at how work-life balance would relate to other areas of healthcare, such as teamwork and safety, climate, leadership, improvement, readiness, burnout, and burnout climate, which is burnout amongst your colleagues. And what you can see in this slide is that the better you're rating your own, or your unit rates your own work-life integration, really the better things such as teamwork and safety, climate are, the better you rate your leadership in your unit, and the more ready you are for improving quality of care, and the less burned out you are. And these things are really important because as we become more anxious, and we have to recognize that our behaviors in the unit, in the NICU, actually will influence our colleagues and will influence the quality of care we provide to our patients. Next slide. I'll be talking a little bit about burnout. We've been talking today about a number of different mental health problems. Most of our research has been on burnout, but you got to understand that burnout is sort of just a one area of mental health concern that is probably on a continuum to further down to depression. There's a number of different ways to define burnout. I think most of it kind of experience it as a sort of a sense of running out of power. It can be measured through surveys in rigorous ways, but I won't go too much into this detail. I think most of you kind of may have recognized or felt increasing sense of some of these features, such as emotional exhaustion or depersonalization during the last month. Go ahead, next slide, please. So we actually looked at burnout in the NICU setting in California, and it turned out that even before the COVID pandemic hit, about a quarter of, these are all providers working in a NICU, reported moderate to severe burnout. And again, it's important to understand this is inversely related to safety culture, and the other problem is that your behaviors and your burnout actually influences those around you. So if you are not burned out, but you come to a unit where there's a lot of burnout now, or a lot of anxiety, pretty soon you will be burned out and experience those same symptoms. Go ahead, next slide. Meredith Mealer published a study where she actually compared or looked at post-traumatic stress syndrome in healthcare workers and found a prevalence of about 18%, which is not all that different from the 25% that's reported amongst active duty personnel. So especially nowadays with all the imagery that you can see from places like New York, working in an acute care setting can feel like being downraged and being shot at in Iraq or Afghanistan. Next slide, please. There's multiple consequences to burnout and mental health problems in healthcare, and these include broken relationships, alcohol use, depression, and even suicide. But there's also a number of professional consequences, including decreased quality of care, which I mentioned, decreased patient satisfaction. Next slide, please. Daniel Tawfik, who's also at Stanford, has been working with me on a number of studies, did a beautiful review of all the different areas in which burnout has been linked to some feature of lower quality of care, lower safety, errors, communication problems, or decreased best practices. And you can, I'm not going to go through all of these, but there's actually been quite a stable effect with a moderate effect size towards worse quality and worse safety reported with increasing burnout. Next slide, please. And so how can institutions respond? And I would suggest that maybe this should really be sort of a tiered approach. The first tier is where institutions make available opportunities for healthcare personnel to meet sort of the very basics of kind of Maslow's hierarchy of needs. So really things like assisting with childcare, helping staff to work from home, helping them to do self-care, do some workouts, those kind of things, and maybe some resilience tools which have already been mentioned and which are evidence-based, and which maybe institutions can help persuade their providers to employ. Beyond that, there are sort of second and tertiary tiers that really need to try to address providers who have more substantial mental health problems. Many of us will feel the anxieties and the burnout in tier 1, but when things get more severe, really there needs to be professional support that is available in a easily accessible and confidential way, and we are providing you with some resources for that. Next slide, please. So this is a screenshot from the Department of Pediatrics Wellness Resources that you can see here, and there's a number of COVID resources. This is available to anyone, and feel free to access these. Maybe I would suggest that we could restructure this page according to a more tiered system, which makes it easier to respond to maybe where people currently are. To offer them the resources that meet their needs more directly. Next slide, please. Why are some of these resilience tools useful? Well, it turns out that we experience the world based on where we are in our mental health. And so in this little example here of a CT scan slice, interestingly, radiologists who tend to like to look at the bright features in these films, 83% did not see the gorilla in the left lung here on the top right portion of this image. Next slide. And so Marty Seligman, who was the president of the American Psychological Society for many years, really is a founder of the field of positive psychology. And many of the tools that you already heard about today, from Headspace and some of these apps, meditation, they really kind of work to improve your ability to notice positive things when they're around you. And this has really been, in our research, a key feature of improving your well-being, your mental health, is to be able to have more access to good things around you when they're happening. Not in order to try to see positive things where there really aren't any, but when there are positive things, trying to notice those really improves your mental health. Next slide, please. One of the tools that Marty Seligman developed was the 3 Good Things intervention, which essentially asks you to think of 3 positive things, and I think Dr. Yeaton suggested doing this with your family at night, and I would only second that. Think of 3 positive things before, relatively shortly before you go to bed, and think about how you played a role in that. And so here's just a study from Dr. Sexton looking at 3 Good Things as an intervention that you do really just for about a week. And after you do this for a week, and this has been trialed in randomized controlled trials, and here in healthcare workers, you see an improvement in burnout, work-life balance, and depression, as well as some improvement in happiness. And this is long-lasting, almost for a year here in this study. The intervention itself is only for a week, but people tend to keep on doing it once they've started it. Go ahead, next slide. And so I wanted to leave you with 3 tools Dr. Sexton and I thought would be particularly useful during this time. And you can access this through the Duke website through the 3 links that are mentioned here. The first thing is the 3 Good Things tool with the bit.ly link. Essentially what it does, will ask you to sign up and answer a short questionnaire for us, and then we will send you every night for about a week to 10 days a quick reminder to just think about 3 positive things, write them down, let us know which kind of feeling you're satisfying with the positive thing that you noticed, and send it up. It takes about 90 seconds per night to do this, and it's been again shown to reduce burnout and shown to reduce depression and increase happiness. A gratitude tool, people have also already mentioned this. This comes out of some of the journaling work from Marty Seligman. This is actually a very nice and brief intervention in which you write a gratitude letter to somebody that you experience some gratitude to, and this could be a family member, it could be a former mentor, it could be any person. And ideally, you write this letter, and it is only a 5 to 7 minute exercise You try to specify why you're grateful to this person for something they did and how it impacted your life. And then if you want this to be really effective, you grab the phone and you call that person and you read it to them. This very reliably improves your mood and helps your own mental health, as well as the person who you're grateful to, for about a month, which is not a bad period of time to just get a little boost. And then there's the third tool is the forward tool, is really about hope, where we're trying to kind of nurture hope during times that are difficult for providers. Now, this is available to healthcare workers. Certainly, if you want to make these available to family members, that would also be quite appropriate to do. All right, I think I will leave it here. Next slide, please. I just wanted to remind you, we had the slide up earlier in the talk, and the slides will be available on the web for you. But here are a number of opportunities for providers that either want to seek help anonymously, of no cost, here in the pro bono project Parachute, or who need somebody to talk to and maybe have more severe mental health distress that needs to be addressed. And next slide. I think we're at the question and answer section. Yes.
Thank you, Jochen, very much. I'm Christina Oldini, Associate Director at CMQCC. Before we end today's discussion, I will go ahead and ask a couple questions that have come in today. Dr. Yeaton-Massey, I'm going to ask you this first question. We had a wonderful reference that was recommended from Dr. Reddy, and I'm wondering if you can go ahead and share perhaps a preference for a screening tool you may have.
Sure, I'd be happy to. So the Edinburgh Postnatal Depression Scale is the one that has been used traditionally. We actually transitioned over to the PHQ-9 and the GAD. So the GAD screens for anxiety and the PHQ-9 screens for depression. And I would recommend that right now if you have the bandwidth to use two instruments, because anxiety is so prevalent in general in pregnancy. And the Edinburgh Postnatal Depression Scale really doesn't elucidate anxiety discrete from depression.
Excellent. Thank you. Thank you. And thank you for your presentation today. Are you, we've got a couple of our OBGYNs on the call today, and we're so grateful to have Dr. Main and Dr. Yeaton-Massey. We had a question in regards to skin to skin. And another question's come in. Can one of you, Amanda or Dr. Main, can one of you go ahead and address what you're finding?
I'm happy to speak to that. It's Amanda. So at UCSF, we are still allowing skin to skin at the time of delivery, and there has not been a change with that. I'm not sure if that was the question.
For COVID positive.
Oh, apropos the positive, we have been very fortunate to not have very many COVID positive patients on our birth center unit. And I have to be honest that I am not sure in the handful of cases that we have had what the skin to skin recommendation has been.
This is Elliot Main. The current recommendation is not to do skin to skin for COVID positive, but to wash the baby, but to allow much more contact shortly thereafter with mask and gloves for COVID positive mom. I think all of these recommendations are going to be reevaluated as we learn more and see more, particularly with moms who are asymptomatic. So I would look at all of these as a point in time. Stay tuned for the next week or next month.
On that note, Elliot, we have a question that just came in about testing for support persons.
So right now we're trying to get every labor and delivery, every woman coming to labor and delivery tested with the rapid test. And I think once that is all organized and settles, we could look towards support persons next. But right now, the focus is on all the pregnant moms coming in.
Amanda,
Thank you, Elliot.
what was the name of the anxiety screening tool?
Oh, the GAD, the Generalized Anxiety Disorder Screen, GAD-7. So it's a 7-question screen.
Thank you. Courtney, go ahead.
Hi, okay, great. Hi, everybody, it's Courtney again. And we have a question, I think this goes to Jochen, in terms of clarifying for the links that you sent, the bit whatever. Are they meant only for healthcare professionals and family, or are they something that can be shared widely?
So we have IRB approval at Duke for healthcare workers and patients, but not for the general public. But you know, if you do 3 good there are 3 good things, tools, videos online on YouTube by Dr. Seligman, where you can just look at how that works, and you know, you can share those links easily with anybody. So you know, we don't have sort of for the general public approval yet. But the resources are definitely out there. And if there's more interest, there's a wonderful YouTube video by a group called Soul Pancake on gratitude.
Thank you. And I think as we close out here, we've got a couple minutes left. Dr. Reed, I'm going to throw the last question to you. And it's the concern that we've made so many gains of family-centered care. And now, because of the current situation, perhaps they're not being as prioritized as they once were for other reasons. Can you speak to this and kind of close us out on that note?
So was this directed to me?
Yes, Elliot. Yeah.
Okay, I'm sorry.
That's all right.
I do think with all the immediate concerns about this novel virus and a lack of understanding of its impact on mothers and babies, that we had to be very tight with our infectious disease protocols as we have throughout the hospital. I also think, though, as we're getting more information in settings that are where the incidence or prevalence of the disease is much lower, which includes most of California, we are going to be able to move a little looser over the next weeks. And I think there is a strong recognition that we need to consider family not as visitors. In fact, in most of our hospitals, support people in labor are the only non-patients allowed in the hospitals. So that's already to a certain degree recognized. So I would again stay tuned, and we have to claw back our family-centered care nature over the next weeks and months. And hopefully that's weeks and not months. And I think one of the keys to that is more testing. You know, I think the nation as a whole has been clamoring for testing, and that's true for labor and delivery and the NICUs as well. So I'm more optimistic looking forward as we're seeing that it's not as, that pregnant women are not particularly singled out as targets for this disease, unlike H1N1 a decade ago. And so I think things will change over the next weeks. Thanks.
Thank you, Dr. Main. Next slide. So we thank you for joining us today. We're so grateful to all the experts who have presented today. For those of you who are attending, you will receive an evaluation survey. We'll keep that survey open for 1 week. We are also in the process of sending out some additional questions that will be optional. You'll receive that by email also. We'll share the CME info in a moment. Next slide. Again, the information shared today is how hospitals, healthcare workers, and families in California are responding to our current situation. We know that each hospital is working with a different set of resources and constraints and they may not be applicable to your hospital setting. It's a rapidly evolving public health situation, and I really want to thank Elliot for ending us today on an optimistic note. Next slide. Here is the CME information. Simply searching for CME at Stanford Medicine will get you to the right spot. This session today is identified as 35776. Next slide. A reminder, the slides and webinar recording will be available at california.ca.perinatalprograms.org within the next day. We thank you for all you are doing to care for patients. On behalf of CMQCC and CPQCC, stay safe and well. Thank you.